Welcome to the program, Leveraging a Team Approach to Medication-Assisted Treatment for Patients with AUD and OUD. My name is Doug Edwards, and I'm the Director of the Psychiatry and Behavioral Health Learning Network, and I'll be the moderator for today's program. It's now my pleasure to introduce you to the faculty panel today. Dr. Arwen Podesta is a board-certified adult psychiatrist with subspecializations in addiction medicine, forensic psychiatry, and integrative medicine. She opened Podesta Psychiatry LLC in 2012 with a team of treatment providers in the area for a multidisciplinary collaborative model. She is currently a clinical adjunct faculty in the psychiatry departments for Tulane and LSU. She also consults for Reentry Court and is president of the Louisiana chapter of the American Society of Addiction Medicine. Dr. Jonathan Chandler is a clinical, forensic, and medical prescribing psychologist specializing in individuals, couples, and families of all ages. Dr. Chandler provides psychiatric assessment, solution-focused psychotherapy, and medication management to patients through Access Health Louisiana, as well as several community agencies in the greater New Orleans area. And he maintains a small private consultation practice. Juliet Villaranga is a probation and parole specialist in Louisiana in the New Orleans district. She has been a probation and parole officer for over 16 years and is currently serving as the Reentry Court Officer for Orleans Parish Criminal District Court. Through the years, she has supervised individuals with substance use disorders, mental health disorders, and individuals with both violent and nonviolent criminal histories. She has devoted her career to determining the needs of those individuals to assist in their rehabilitation to reduce recidivism. Today's program is provided by the North American Center for Continuing Medical Education, LLC, an HMP global company, and supported by an education grant from Alkermes, Inc. Now, during the program, you can type in your questions for the presenters in the Q&A box to the right of your screen, as well as upvote questions submitted by other attendees if you would like to see their questions answered. We will try to answer all of the most popular questions with the time remaining at the end. The learning objectives for today's session are to evaluate key efficacy and safety data for medications approved for the treatment of AUD and/or OUD, as well as potential long-term impacts on patient outcomes. To identify systemic barriers for the use of medications for opioid use disorder, MOUD, and medications for alcohol use disorder, MAUD. And to implement cross-team processes to ensure that MOUD and/or MAUD are considered for every patient. Ladies and gentlemen, I will now turn it over to the panel to begin the presentation.
Thanks, Doug, for that introduction. So I'll start here with what Reentry Court is. So Reentry Court is one of the specialty courts that are in Orleans Parish Criminal District Court. Once this person is released from the prison and they return back to the community, we hope that they have obtained their trade in the jail along with their GED. They come back into Reentry Court. Here, the court has the authority to use any sanctions, positive reinforcement to help with resources to support the prisoner's reintegration, just as it's commonly known that drug courts do throughout the country. This is to promote positive behavior by the returning prisoner. The expectation is that the focus on the reentry issues in this court will help reduce the recidivism rate of the returning prisoners and will encourage a broad-based coalition to support the successful reintegration of those offenders. Here in the Reentry Court, our team specifically is the judge, the program coordinator, the case managers, social worker, peer mentors, we have the primary care nurse practitioner, and of course us, me, the probation officer, the psychologist, and the psychiatrist. Orleans Reentry Court was developed primarily through the Justice Reinvestment Initiative, also known as JRI. It was developed to address the high incarceration rates of nonviolent offenders in prison, the low-level technical violations that brought those individuals back to jail on a full revocation, and those offenders returning back to prison for what we call those technical violations that do not include any type of felony arrest. Legislature passed this reform to authorize the use of administrative sanctions for technical violations of probation and parole. Specifically, instead of us going in front of a judge to address those minor sanctions that could be addressed in office by giving me the authority to apply community service work for a positive drug screen, or more increased reporting for issues that need to be addressed, whether it's substance use disorder or alcohol use disorder. Also the authority to give more drug screens at the office rather than ordering them into the courthouse to have their drug screens addressed by the judge. So JRI has granted funds to develop the pilot programs in specialty courts. As an offender is being released from prison into reentry court, this is where the intake process begins. So the individual is going to come into the office. I will review those conditions of supervision, those state standard conditions that are automatic to everyone that is on probation in the state of Louisiana, and any special conditions that the judge has specifically ordered for that offender. They are going to sign the grievance procedure, and they're also going to sign the authorization to release confidential information, which we will in turn use for any outside programs that we place this offender in. Along with the intake process, we also have the Tiger assessment. Now, the Tiger assessment is a Louisiana-specific assessment, and Tiger stands for Targeted Interventions Gaining Enhanced Reentry. This is a risk and need tool that we are required to do with everyone that comes into the probation and parole office. This is going to address deficits that exist for an offender that may cause return to prison. This is also known as their need. It's going to address the offender demographics, known as their risk. So these are the categories that are going to be addressed to determine this individual's needs. I'm going to ask questions in regard to their employment, their history, and family history of employment. We're going to ask questions regarding their education, how far they've gotten in school, did they have any learning disabilities while they were in school. Going to address their substance abuse, current and past use. I'm going to address their antisocial thinking and peers. This is going to tell me the type of individuals that they hang around with and their ways of thinking. I'm going to address their mental health and depression, their housing stability, and also their criminal history, whether it's violent or nonviolent. So the Tiger outcomes will determine the treatment pathways. This is going to tell me what referrals that I need to make to the community programs. The Tiger assessment will also give me a supervision level. This supervision level is going to tell me how often I need to make contact with this individual. It's going to be on an elevated maximum to a self-reporting.
So we're going to start talking about different types of treatment for the substance use disorders that Juliet does the intake with that Tiger assessment. And so we're just going to get into how we treat in reentry court, and also isn't just for reentry court. This is just an overview of treatment in general.
Thanks, Arwen. In evidence-based treatments for substance use disorders or substance dependence, in this case, we went ahead and merged the alcohol and opiates treatments together because they are very similar. And as Dr. Podesta said, that, even outside of reentry court, a lot of the first line happens with the primary care. physicians. There is an SBIRT model that is used where you utilize brief interventions for patients who screen positive for harmful drinking or harmful drug use. A lot of that is in knowing where to go from there as well, through motivational interviewing, making the appropriate referrals to the psychiatrist or psychologist or other substance abuse programs. Even at this level, at the first line, even though most primary care physicians are not trained necessarily directly in substance use disorders or mental health disorders at all, they can still build that rapport with their patient. They usually know the patient for a very long time and they've been treating them ongoing. So the patient is much more likely to be motivated by wanting to adhere to any kind of referrals or treatments that the primary care physician makes. So this is why this is very important for it to start at this level. Once they get referred to the proper treatment programs, that is when motivational interviewing is also utilized, but this is much less brief. This is much more extensive in motivation enhancement therapy. There's also lots of evidence that supports this treatment, especially for someone who is heavily drinking or heavily utilizing opiate-based medications or even heroin. The number one first line for many substance use disorders is cognitive behavioral therapy. They've done lots of meta-analysis and lots of studies that support that CBT focuses on altering those cognitive distortions and negative behaviors that are motivating and driving the patient to utilize or abuse medications or drugs. What I really like about reentry court is that we get to use contingency management quite frequently. It's based in the fact that if they can perform to a certain level and adhere to the things that are recommended for them, both on the court side as well as the treatment side, then a lot of benefits come to those patients who do that. They're much more motivated to avoid certainly going back to jail or serving more time, get the treatment that is provided for them is a reward in itself. And most of the time they, through the motivational interviewing, CBT, and the CM, they come to that conclusion for themselves as well. So also at times we utilize 12-step facilitation, which is, going by the big book or some other 12-step models in directly with the patient. And it's been shown to be as effective as CBT. And with certain patients, it tends to work a little bit better than others. In my practice, I use a lot of mindfulness-based interventions, trying to bring awareness to the patient's body as well as the mind, and being able to connect those two so that they aren't seen as different things. Sometimes there has been a disconnection with the patient since they've been through prison and sometimes jail. And it seems like a lot of the ways that patients tend to reach for or try to self-medicate using opiates and alcohol is because they are trying to reduce the overall or underlying anxiety that they suffer from. So using mindfulness-based intervention, I'm able to help them to reduce that stress level without utilizing anything else. At times, we do involve the patient's partner, and other times use family-based therapy with the reentry court. We definitely will use the information that comes from those collateral sources are very helpful in treating the patient as well. I believe that reentry court is a very good example of multi-systemic therapy. I believe that that's what we do from the very start of when they get out and go to Judge White's court, and then they see Juliet, and then they get their referrals from there. And so I believe that our program presents a very good example of that. And then there's the continuing care. And in fact, we've definitely worked hard to find those resources in the community with the whole team, finding both primary care and as well as mental health care and substance use care to go beyond even when they graduate the reentry program.
Continuum of care is necessary for all people struggling with any mental health or addiction related things. You have to have the inpatient, the residential, the outpatient, the IOP, making sure that you have a looped in continuum of care with your patients.
So now we're going to address the drug testing. With the individuals that I supervise, I am normally going to ask for a drug test if I was given some information by a family member or if they missed last month's meeting with me. So normally we'll do a drug screen, a urinalysis in the office where they will give me a sample in the cup and it will screen for a multitude of drugs. And from that positive drug screen that I get or their admission, sometimes even before I've given them the cup, they're going to admit to me what they're going to be positive for. I will make my referral into the community for whatever substance it is that they're using, how often they're using, and then also their willingness to participate in a program.
And that's the same, drug testing is really part of treatment for people that have an addiction or drug dependence issue. So drug testing is part of treatment. And so in the forensic world, for those that are in the criminal justice setting, or for those that are in an outpatient clinic, we really want to make sure we include drug testing. With a point of care, that's a screen. And then in the clinic, if you need to get a confirmation, then you need to do a send out. It is imperative that if we're going to take someone's rights or freedom or livelihood away, like their job, or put them back in jail, that we don't just use a point of care unless we have other evidence, the point of care being the spot testing. We need to have an actual confirmation to do anything like that.
So we follow up with our coordination of care, and here we'll have virtual meetings now since COVID with the case managers and the program coordinator, specifically target each individual in the reentry program, address whatever issues they are having. And then that's when they tell me where I come in that I need to enforce some things that they did not take care of on their own. Then also we have the reentry court docket days. Here, they are also going to speak with the case managers to address any issues that they have. The case managers will then in turn provide the judge with a summary of what's been going on for the last month with this individual. And also we are going to speak with Dr. Podesta and Dr. Chandler, and everyone's going to be in one forum to address each individual specifically, and everyone provides their input as to how we're going to continue with this individual.
And so for reentry court docket days, which we have monthly, the judge is obviously the final decision maker on the needs and actions, but it is a team approach to best help the individual that I call a patient and that, Juliet calls a probationer, but that's who we are addressing. I want to talk about the technology because we need to have that release of information with all entities. And we need to document share. Like I need my notes to get to Juliet, or I need, so we use different ways of doing that, either like a share document on a platform that's HIPAA approved. But there are some continuity of care programs that are applications that we can look for the future. So that's hopeful that we'll have something like that in our spectrum soon. To start off our section on alcohol use disorder, we're going to watch a video of a patient telling her story.
Hi, I'm Caitlin, and I think I might need some help. I've always had anxiety since I was young. When I was a teenager, I started drinking, and it helped me loosen up. In college, I was prescribed benzodiazepines for anxiety, and that helped a lot. I still drank a lot too, and sometimes would black out. Some bad things happened, and I started therapy. My therapist helped me with anxiety using cognitive behavioral therapy. I was able to stop the benzodiazepines and did pretty well for a while. I got pregnant in my late 20s and even stopped alcohol. After my baby was born, I had postpartum depression and anxiety. I found myself drinking again. At first it was social, then every night with or without anyone else. By the age of 30, even though I was working and being a mom, I found I was drinking every day. It helped me stay calm, or so I told myself. It was getting more and more regular, and even sometimes before I had to do a presentation or something, I would have a drink or two in the morning. My partner and daughter convinced me to try and stop, and around 39, I went to therapy again and started 12-step. It was so scary. I stopped cold turkey. My partner found me on the floor the second night. She said I had something like a seizure and fell out of bed. Later, I found out that you shouldn't stop cold turkey because it can have really bad problems. I went to the doctor and they gave me benzos again, and I took a week's worth in lowering doses, and then I stopped. 12-step was helpful for a while, but I didn't really connect with some of the parts of it. My family helped a lot too, but I had cravings almost every day. I would imagine having a drink and even that calmed me down. I would almost salivate if I saw someone on TV having a scotch, my usual drink. About 6 or 7 months later, I had a super stressful week at work. One day on the way home, almost on autopilot, I stopped at one of my old haunts and grabbed a drink. After 2, I just kept on autopilot and went to the liquor store and got a bottle. And frankly, I haven't stopped since. I don't ever drink in the mornings, but I have at least one drink nightly or I can't sleep. And I swear, I wake up craving. My partner doesn't think it's out of control, but I feel like I'm chained to the cravings. I don't tell her my inner thoughts, but it really gets me. She has no idea.
Okay, so in alcohol use disorder, the studies are pretty clear about 4 to 40% of medical and surgical patients have problems related to alcohol. It causes over 85,000 deaths each year. So it's a very big impact, as well as a huge impact on the annual economic cost of treating alcohol use disorders. They estimate that to be over $250 billion. Roughly 1 in 10 of those deaths among working age adults results from excessive drinking. We particularly see this with places that tend to have more colleges around, which New Orleans happens to be one of those. So I think it's imperative, especially here in New Orleans, to have these types of treatments available. The consumption, especially at harmful and hazardous levels, is associated with more intimate partner violence. And we've especially seen that even more with COVID. There's been an increase in alcohol consumption, as well as an increase in intimate partner violence. So heavy alcohol use can contribute, obviously, to more injuries, more diseases of the liver. Emergency department visits involving alcohol consumption increased by at least 61%. And they have totaled in the amount of between $4 and $15 billion. That's an astronomical amount of money that is costing our healthcare.
Wow. But we have some tools. So Dr. Chandler already talked to you about some of the psychosocial and behavioral change tools. And Juliet talked about some of the assessments and ways to refer into care in the criminal justice system, at least. And I'm going to talk to you about medications for alcohol use disorder. So FDA-approved medications are Acamprosate, Naltrexone, which comes in an oral and extended release form, Disulfiram, and there are non-FDA approved medications that are frequently used, particularly to move people off of alcohol, which include anti-epileptics and sedative hypnotics like benzodiazepines. The APA guidelines in 2018, because what you saw, those numbers that Dr. Chandler showed you just a moment ago, are really high, and it's getting worse, and even worse during a pandemic. In 2018, though, the APA released new guidelines on medication treatment for alcohol use disorder, and they state specifically naltrexone and acamprosate are recommended to treat the patients that have moderate to severe AUD when certain other approaches have not been effective. Disulfiram produces the physical reaction. It's called a disulfiram reaction. So it's the negative part. We'll get into that in a minute. If alcohol is taken within 12 to 24 hours, it's not generally used as the first line of treatment. And then these anti-epileptics, topiramate and gabapentin, were suggested by the American Psychiatric Association as medicines for patients with moderate to severe alcohol use disorder, but only after they've tried naltrexone and acamprosate first. So these are these newer guidelines, which is fantastic. So disulfiram, people know it as Antabuse, that's the brand name. It's generic only. It was FDA approved for alcohol use disorder in 1951. It inhibits one of the pathways that is how alcohol metabolizes. So it basically inhibits the alcohol from metabolizing. So you just get the negative part of alcohol and none of the euphoria. So you get an acetaldehyde buildup, and it causes flushing, nausea, vomiting, dizziness, and sometimes can cause some other concerning things. And when someone takes it and has alcohol. So sometimes I've had patients on disulfiram that they used an alcohol or mouthwash or cough medicine or ate something with rice wine vinegar in it, and they had the disulfiram reaction. The purpose of the disulfiram reaction is to have a negative outcome when you drink, and so have a psychological reason for hating drinking. And so that's why this medication works. It's best for people that are highly motivated and can be observed taking the medication, because it won't work if you don't take it. In 2014, there was a big meta-analysis that showed that disulfiram is safe and efficacious compared to abstinence supportive treatments or to no disulfiram. It has no street value. It has no abuse potential. Okay, acamprosate is another medication that's FDA approved for alcohol use disorder, and it was approved in 2004. It's dosed 666 milligrams 3 times a day. It goes through the kidney. The reason that acamprosate works is with that GABA-glutamate balance restored, it blocks the reinforcement of alcohol. So it basically cuts cravings, is how it's touted. There are multiple meta-analyses that found acamprosate was associated with significant improvements in abstinence and in cumulative abstinence days. Also, no abuse potential, no street value. Then there's naltrexone, and naltrexone was FDA approved in 1994. It's an oral pill. It's dosed at 50 milligrams once a day. Some people start at 25 once a day, and some people dose at 25 twice a day. It is a mu opioid antagonist, so it blocks the opioid mu receptor, and that makes it so that it decreases the effects of alcohol, the reinforcing effects. It decreases some of the Q and alcohol-induced cravings. The results are fewer drinking days, less alcohol consumed, decreased craving, and the clinical trials showed some side effects of some GI issues and dizziness and syncope. This medicine also has no street value and no abuse potential. There's an extended release naltrexone that was FDA approved for alcohol use disorder in 2006, and it's a once a month, which is how great to not have to think about taking something daily, or to choose to not take something if you want to go have, a party weekend or something. So naltrexone extended release didn't have any need for oral lead-in, so you can just start the naltrexone injection once a month. It works in the same way the oral naltrexone works. It's an opioid antagonist. The pivotal 6-month trial was that extended release naltrexone plus psychosocial support decreased heavy drinking days by 25% and decreased frequency of drinking. Now, when Dr. Chandler was talking about heavy drinking days really causing interpartner violence and being root of a whole lot of both economical and psychosocial issues, I think that's quite good to decrease heavy drinking days by that much. Ideally, if you're going to use extended release naltrexone, someone might stop drinking 7 days prior, because those studies showed that they had an improved outcome even more than 25%. There are side effects that can occur, just like in any medicine, but the side effects that may occur in extended release naltrexone are nausea, vomiting, injection site reactions, some inflammation or stiffness, muscle cramping, some dizziness or cardiac syncope, sedation, eating issues, and other appetite disorders. And again, this medication does not have a street value. It has no abuse potential. Okay, so now we're going to talk about opioid use disorder.
And to start off our opiate use disorder section, let's watch a clip from Lee telling his story.
Hey, I'm Lee Legend. People just call me Lee, though. I got out on this early release program with Judge Red. She's pretty cool, but sometimes she rides me. Like, I don't even know why. I think she's harder on me than any other dude up in here. I mean, I follow up with everyone she tells me to, but a guy's gotta work, you know? See, I used to have a drug problem. Keywords, used to. So that's probably why they all think I'm using again. If I miss just 1 or 2 appointments, like I said, I have to work. But the kind of work I do is why I have the pain I have. It's a catch-22 because I have kids to support. I work offshore cleaning these huge boats, so that's why I miss them calling. Doctors, judges, caseworkers, lawyers, etc. But I call them right back when I get back to port. My girlfriend also says I don't communicate very well, but neither does she. And neither do half these guys in this program. But you don't see Judge Red all up on them. Anyway, long story short, Suboxone works for me. I learned that when I got the first script from one of the providers in the reentry program. Problem is that I was denied for Medicaid and my job won't pay for insurance. And I don't make enough to pay for my own insurance, so I couldn't afford the script each month. So I took things into my own hands and I buy the strips off a guy who gets them from the Suboxone clinic, and I cut the strips to make them last as long as I can. I have a legit script in case I test dirty. I don't see why everyone is making a big deal about this. They wanted me to go to the MAC clinic, but I tried to go and they turned me away for the same issue. No insurance and no money to pay for it. I just need help getting everyone off my back. So I'm willing to get the Vivitrol shot to accomplish that.
So for opiate use disorder, we talked earlier how a lot of the treatments for both of these, alcohol use disorder as well as opiate use disorder, are very similar. What we're seeing in opiate use disorder is a huge increase of overdoses. And that could be for a lot of different reasons, and we can speculate what those are. But if you see from 2014, a huge jump into 2016, and then even bigger jump into 2018. And I suspect as 2020 was what it was, there was probably another huge jump. Monthly overdoses increased dramatically during the pandemic. As we said, we can get some of that data, but obviously we don't have a cute little chart to show you. But we know, for instance, that like the increase in intimate violence, we're also seeing more drug use as well. So people are trying to cope with whatever means necessary, increase stress, and take away a lot of coping skills like meeting up with family or meeting up with friends or going to a restaurant or going to a movie. During COVID, we haven't been able to do those things. So we're taking a lot of coping skills away from people to keep everyone safe. But at the same time, there's an increased stress level because of jobs that are not there anymore and just being in the house with other people for extended periods of time is probably the reason for the monthly overdoses increasing dramatically. For every 10 suspected overdoses reported to ODMAP in May 2019, 14 overdoses were reported for May 2020. So I suspect that our number for that first chart will be along the same trajectory, unfortunately. But one thing that has been good about COVID is that it has opened up access to care for people who wouldn't normally have gotten that treatment. To be able to provide telehealth for patients who wouldn't normally be able to get into your office, I think has dramatically improved that. So I'm hoping that we can make a dent in those numbers. The nationwide ODMAP allows the EMS and other public service and medical personnel to input fatal and non-fatal ODs for each city, county, and state, in our case, parishes, so that we can see the general spikes that are happening. As you can see, is from 2019 to 2020, just as we're suspecting, we have the data through April, and we'll probably have the data, soon for the rest of the months. But I can't say that it probably got much better throughout the year, unfortunately.
Fentanyl is the main synthetic we're talking about, or its analogs such as carfentanil or others. It's 80 to 100 times as strong as morphine. It often is not on a regular drug test. So when Julia is doing the drug testing in office, or I'm doing drug testing in my office, or we're doing them in jail, we have to do a specialized separate test for the fentanyl test. And it's important to know if someone's on fentanyl because it is an opiate. It does sit on the opiate receptor. And if you're going to give a medication for opioid use disorder and they have fentanyl in their system, you could cause precipitated withdrawal. I want to make mention of this MOUD. So we used to say MAT, medication-assisted treatment, for these types of FDA-approved treatments for alcohol and opioid use disorders, but we're now calling them medications for opioid use disorder, MOUD, and medications for alcohol use disorder, MAUD. I want to compare using medications for opioid use disorder versus not using medications as an abstinence-based treatment. So using medications plus psychosocial therapy and counseling, there were many, many studies done comparing these two arms with or without medications. And the studies really show that with medications, we have a much better outcome. So the 2015 study comparing 650 pain pill addicted patients, some of them with medications, either buprenorphine or naloxone, versus those who did not have any medications, 80% of those with the medications versus 36.6% of those without succeeded. Now, when I'm talking about succeeding, as in not relapsing, think about how many people overdosed, all those numbers that we saw of people overdosing and dying. So if someone has nothing on their opioid receptor after they come off of opioids, they're not only 36.6 likelihood of staying abstinent, all of those people that relapse may overdose and die. So that's the big concern. In 2003, there was a study where 40 opioid use patients, they either were given buprenorphine or placebo over a year, and everyone in the placebo arm relapsed or dropped out of treatment by 2 months, and 4 died, whereas 75% of the patients in the medication arm stayed in the study by a year and none died. So what are the medications for opioid use disorder? Well, we have 2 reasons that we would use medications: to detox, because people coming off of opioids, when they detox, they're going through a lot of physical and mental anguish. And so we might use medications, and there's 3 kind of categories. So the opioid-based medications like methadone and buprenorphine are available for detox. And then we can also do a non-opioid-based detoxification using some supportive medications and lofexidine, which is FDA approved for opioid withdrawal. And then we could use an antagonist-based detoxification, which a lot of places don't recommend any longer. And then the other reason to use medications for opioid use disorder is for relapse prevention, whether it's short or long term. And agonist maintenance is with methadone, where there's a partial agonist, which is buprenorphine, and then antagonist or a blocker, naltrexone. Methadone's been around since 1947. Everyone here is aware of methadone. It's a full agonist, so it works to fully sit on that opioid receptor and cover the opioid receptor, but giving opioid effects. The effects last about 24 hours, and so we do once daily dosing with methadone. Prevents withdrawal because it binds to the receptor tighter than most opiates and longer, and so it reduces cravings and it reduces use. It facilitates people getting into rehabilitation. With methadone, the patient has to go to a clinic daily, and in our justice reentry courts, it's kind of challenging for these guys to come out and go to a clinic daily. So this might not be the best recommendation for everybody. It really requires making sure that there's transportation and that there's availability of them getting to the clinic daily. Now, that's been slacked since COVID and they do more take-home meds, but in general, it's a federal requirement that they go to a clinic daily for a period of time. There is an abuse potential and there is a street value with methadone. Buprenorphine is a partial agonist, meaning it sits kind of partly on the receptor. So it both turns the receptor on and kind of turns it off a little bit. It's been FDA approved since 2002 for opioid use disorder. And you have to have a mandatory certification from the DEA. Actually, this just changed a couple of days ago, where any prescriber can prescribe buprenorphine for opioid use disorder without their special X number. However, we are still required, if you're prescribing to a lot of people, you're still required to have that special X number. Office-based, so they don't have to go to a clinic daily. You can do a month's supply or longer. It's a partial opioid agonist, as I mentioned, and it does have some analgesic properties. If you take too much, it turns more of the receptors off and on. That's called a ceiling effect, so it doesn't have quite the risk that the full agonist might. And it has, as street value, it has abuse potential, but most people that do take it don't take it to get high, but usually to bridge to treatment. But there's still a street value, pretty significant. And then naltrexone, which we talked about for alcohol use disorder. Naltrexone was actually approved for opioid use disorder in 1984. And naltrexone, you know, as I mentioned before, it comes in the oral form, the pill, but it also comes in the once a month extended release. And extended release was FDA approved for opioid use disorder in 2010. And as we said before, it's an opioid blocker. It sits on the mu receptor and it blocks it. So when opioids come in, I always think of the receptors as like a baseball mitt. So when opioids come in, they can't sit on the receptor. So it decreases positive reinforcing effects, decreases cue-induced craving, and it has no street value and no potential for abuse. So some pivotal studies for extended release naltrexone for opioid use disorder. In 2011, there was a pretty significant 6-month study that showed that those that were using the extended release injectable naltrexone had higher rates of complete opioid abstinence versus placebo. And of course, both of these, we always want to include psychosocial support with any treatment, especially any study. For those that attained complete opioid abstinence, 36% of those in the extended release naltrexone versus 23% of those in the placebo arm. And the median of the extended release naltrexone injectable group had a confirmed abstinence for 90% of the weeks in the evaluation period versus 35% for those in the placebo group. And so let's talk about some head-to-head studies between buprenorphine and extended release naltrexone. So there was something called the XBOT study, which was a National Institute for Drug Abuse funded, not funded by the pharmaceutical companies, had a pretty decent number. It was over a 24-week period. And one of the realities is that it was more difficult to initiate patients. So getting people onto extended release naltrexone was hard for some, versus harder than getting people onto buprenorphine. And so that affected the overall relapse rate. But once they got people onto both of those medicines and they were in one arm of the study or the other arm in the study, they found that the medications were equally safe and effective. And this is a secondary endpoint of the study was opioid cravings. And the green is showing that those patients that were on buprenorphine and naltrexone, you can see their cravings dropped significantly within the first couple of days, as did the same, virtually same outcome for those with the extended release naltrexone, decent craving coverage for 24 weeks. And then there was a similar study called Tanum, but it was done in Norway, and it was a 12-week multi-center outpatient study. And they took people after detox, and they put some of them in the buprenorphine arm and some of them in the extended release naltrexone arm. And the ultimate outcome was that extended release naltrexone had fewer cravings for heroin, and they had better treatment satisfaction. So Overall, with these two head-to-head trials that are non-pharmaceutically funded, both medications are equally effective once you get them started on it. Starting extended release naltrexone is challenging because you have to detox them and be abstinent first. And there are some research hurdles that we need to overcome. So we need to find optimal ways, and there are many studies, to get patients from full agonist opioid on the street onto naltrexone. So how do we keep patients adherent to treatment? That's a good question. And in specialty courts like Reentry, where we have this whole team approach, it's much easier, honestly, than in an outpatient setting. Even if this is an outpatient clinic or a primary care setting or a community clinic, we want to have a team-based approach with collaborative care. So intake, and in our setting, Juliet started the intake. Always, when you're working on someone with addiction, we have to get that PDMP, the prescription monitoring report. Nursing is involved. Maybe one of the prescribers is a primary care prescriber, maybe a psychiatrist. We have to have a therapist, even if they're not in your office. We need to include the behavioral and psychosocial support. And so having a release of information, if you have a therapist outside your office or having someone in your office, and then drug testing as part of the treatment. So care coordination in the forensic setting, as we've talked about a lot, we really love having this team-based strategy to ensure that we use the medications and that we monitor the medications. Case management is a huge part of this as well, and it can be 1 to 3 times a week or less frequent, depending on that Tiger assessment that you saw. We'll have the needs and risk laid out, and so we'll do case management accordingly. And then enforcement to monitor, and that's of course also assessed and determined by the intake. And then drug testing, and that can be done at clinics or at docket day or both. And then all the clinicians, so myself as the psychiatrist, we have a nurse practitioner, and we have Dr. Chandler, psychologist. So we all have releases of information with all of the rest of the team. And we even have some buprenorphine clinics and other medication clinics that we have releases of information with. And then in our setting, we get to use contingency management too, because they might have a stipend for successful trainings for the reentry people. There are some barriers to getting people with opiate and alcohol use disorder into treatment, whether they be in a forensic setting or in an outpatient setting. And so there are barriers. So how can we remove these barriers? We have to decrease the stigma of treatment. We have to decrease the stigma of the disease. We have to increase access to medication treatment, really incorporating it into primary care, having someone walk into a clinic to see their primary care physician, and that physician be able to ask the questions and maybe add the prescriptions. We need treatment on demand. It's really hard for someone to decide they want treatment one day and have to wait 2 weeks for an appointment, because I guarantee they're going to change their mind and have other influences. Having expanded coverage and patient appointments, including ancillary supports like therapists in the office and assistants that know about addiction. In a forensic or criminal justice situation, incorporating the evaluation and treatment into the jail and prisons, and with a really good coordination of care upon release. And that is happening all over the country through justice reform and justice grants. And I think it's going to be more common than not in the near future. So as we've talked about care coordination, it's a team effort, and we have to have interagency coordination, and you have to have the releases of information, but it can be with email communication. I mentioned before this app-based care coordination, which there's a couple that are out there that are really very helpful, but we have to share data and share information and share records to help best coordinate for the patient to be successful.
Okay, in addition to overcoming these barriers to effective alcohol use disorder and opioid use disorder, I need to be prepared to address these barriers that the individual will not tell me when I first meet up with them or when I first order them into some type of aftercare treatment. They're not going to tell me that they don't have a babysitter to go to the program or to go to the appointment until the time comes that they're supposed to be at that program. So I need to know what barriers or what excuses this individual or past individuals have come up with in the past so that I can address them immediately. I will give them bus tokens so that they don't use the excuse of transportation. We also have reentry court docket days, and this specifically addresses people's driver's license, where the court will give these people credit for time served in the jail in lieu of paying any fines that are owed to the court for any traffic violations.
Okay, and we'll open it up for questions and answers.
Thank you for quite an insightful presentation. And we have a lot of questions from the audience, so let's dive right in. Dr. Podesta, I'd like to start with you. Let's talk about perhaps the biggest thing that's in the news today. What's been the impact of COVID-19 on the program?
Yeah, wow. Well, we've had quite an impact on our reentry program and all of the drug and alcohol treatment programs that I'm aware of nationwide. For our reentry program and most of the courts around the country, our docket days have been canceled or postponed. We have less monitoring, face-to-face monitoring by someone like Juliet, and less monitoring by drug screening. Obviously, everybody is going through a ton of stress, us included, but the patients and the offenders are very challenged, and so they fall back to old coping skills pretty easily. And then, in addiction treatment, we've had medication issues, being able to get refills of buprenorphine if you're in other states, methadone clinics not being able to do their daily doses because of distancing and cutting that and doing a fewer percentage of face-to-face. But then some states did not adopt the federal relaxation of the methadone clinics, being able to provide take-home dosings. So all of those are concerning, and it's been a very big challenge. And unfortunately, our population in treatment has suffered greatly.
Let's move on to the next question. I think this one, Dr. Chandler, is probably for you. Some recent studies have cast some doubts on the broad applicability of mindfulness. What are your thoughts on that in working with this population?
Yeah, and I can understand the skepticism and the concern about it, because I think that is true. Actually, it's not for everyone. I think mindfulness can be one of the tools that we can utilize, and if it works for that patient, then great. If it doesn't, then we have a whole host of other tools that we can utilize. But if you think about the mechanics of trying to measure mindfulness and the patient's ability to get into that state of mindfulness and meditation, it's really difficult to obtain that or measure that in session with them. You really have to have an fMRI to really study what the brain is doing or not doing. And so, without those measurements on a daily basis, it's really difficult to ascertain whether they are benefiting from it or not. Except for them to tell us, yes, I feel better when I meditate, when I do this mindful practice. I feel better in the morning. I start my morning like that, and I have a better day, and it reduces cravings, and I don't think about it as much. And when I check in, periodically throughout the day, I feel better. So it's really kind of anecdotal. We go based on patient to patient.
And speaking about patient to patient, and Juliet, this kind of reminds me of the next question. I'm particularly interested in this one. How well are virtual meetings working with your criminal justice population clients? How's that going?
Oh man, I think we can all agree it's kind of still a work in progress. We need to see what's going to work with this particular individual. I'm used to being out in the field. I need to have direct contact with these guys. I want to see them in their environment. I want to go in their home and see what their living arrangements look like. And we can't. So I feel like this reduced field contact that I have with these guys, now I have to crank it up and do more virtual contact. I need to do more telephone contacts. I'm I'm dependent more on how much they're willing to give me because I can't see it with my own eyes. So it's a work in progress for me right now.
I think there's a lot that's lost, but from my standpoint as a physician, that normally the patients come to my office, and Dr. Chandler and I've talked about this too, you know, we see them in not their home environment. We don't see them like Juliet does, and we see them in our environment, which can be good. But now I'm, you know, virtually going into people's homes. Just before this, I had someone go get all their medicine and see what else he's taking because he didn't remember the names of them. So that was a real benefit. And with addiction patients, I've had other people on our team talk about, oh my God, I looked and she, you know, he says he's sober and he's not using and there's no paraphernalia in the house, but she has them walk around and she's like, what's that on the table? Tell me about that. So it's actually quite insightful. So there's both. There's positives and there's certainly negatives. Just the same as, you know, there's more access, but there's also a limit of reach, of outreach.
And
And
Dr.
just
Go ahead. Yes, Dr.
I
Chandler.
was just going to say, just just to add to that, to some of the benefits, for certain there are some drawbacks, but just to add to some of the benefits, that we've definitely had a lot less no-shows, because we can contact the person where they are. There's hardly any excuses that they could give us. The only downside is it might be just a phone call, but a phone call would be better than a complete no-show of not seeing that patient at all. So there are some pros and some cons for sure.
Next question, go back to you, Dr. Podesta. There has been some discussion in the news lately about the X waiver and if it's in effect or what's changing with the incoming administration. Do you have any thoughts on that or any updates for our audience?
Yeah, at 10:03 this morning, I received an update on that. So X waiver has been limited to people that take the SAMHSA training and have this special waiver that they can only prescribe buprenorphine after the special training. That's been historic. We used to be allowed to prescribe to 30 patients, then to 100 patients. Then if you had special extra training or had a fellowship under your belt like I do, I can prescribe to 275 patients at any given time, buprenorphine in particular. On January 14th, the HHS announced a practice guideline to allow all doctors to prescribe up to 30 patients a year, all doctors with a DEA number to prescribe up to 30 patients a year. Up to 30 patients at a given time, not a year. And so that was loosening, and that was a great idea. However, HHS released something this morning, a statement saying, unfortunately, the announcement that was made prematurely. Therefore, the guidelines previously announced cannot be issued at this time. However, they're working with interagency partners to examine ways to increase access, reduce overdose rates, and save lives. I suspect that probably was having to do with one side, having an intention, and the other side, like the enforcement and the DEA having, putting the brakes on just for safety reasons and making sure. So we'll see. But there is no change in that guideline currently.
It's constantly changing situation, but I guess that's just the times that we're in. Let's move on to the next question. The question is, in multidisciplinary treatment across the continuum of care with community-based agencies or providers, who is it best to own the treatment, and who or how does the primary provider ensure that the partnership with other outpatient providers, with the criminal justice system, making sure that all of those checks and boxes are being crossed?
I'm going to jump in on that one. We are so siloed, more so now because of COVID and being, virtual and not being in our offices. And we are siloed anyway in behavioral health, where we'll have a therapist and then myself as the doctor, and in enforcement, and the psychologist. So it's very healthy to have interagency communication. Unfortunately, sometimes that's really restricted by time and also HIPAA. There are apps. I think I mentioned this. I'll throw in a name of one that is pretty cool called Sage Surfer that some agencies are adopting. It's not adopted very around. It's a HIPAA. There's lots of things like this that are out there that are HIPAA compliant coordination of care that when you're in different agencies or different out under different groups. But it's hard, and in my opinion, but I don't always see this. In my opinion, the primary care should be the conductor, or someone should be the conductor and take ownership. In our reentry court, the judge is the conductor because she's the judge, and but she might not know outside of those of us that are on her team. She might not know what's going on if someone has HIV and is seeing an HIV doctor. That doesn't need to come into the courtroom. So it's really a matter of relationships. And, Dr. Chandler, Juliet, and myself, we've built a great relationship, and we'll work together even if we're not with the judge in capacities. But I think it's having referral spreadsheets, relationships, having meet and greets with people in your community, and making sure you have email blasts to just know that you are available to talk as long as you have a release of information from your patient.
Mm-hmm. Mm-hmm. Well, obviously, it's clear from the presentation today that you all work together and work towards helping people with addiction begin and maintain their recovery journey. So I'd like to thank each of you for sharing your approach today and taking some time out of your busy schedule to share with our participants. And ladies and gentlemen, I'd like to thank you for joining us for today's program. This concludes today's webinar. Thank you for joining us.